Epithelial disorders arise from the epithelial layer of the oral cavity, which constitutes most of the tissue in the mouth. Throughout our journey through these various types of lesions, please keep in mind that number one, lesions, benign and malignant, come in many shapes and sizes. And number two, that a definitive diagnosis only comes with a biopsy, a sampling of tissue to determine exactly what the lesion is. We'll now cover some benign disorders. The squamous papilloma is possibly HPV related and is treated by excision. And it may be excised in order to rule out the possibility of malignancy. Nicotinic stomatitis is not considered malignant and may or may not resolve if the patient quits smoking. The red dots are dilated openings to salivary ducts. The white halos are hyperkeratotic tissues surrounding the duct openings. Hyperkeratosis is caused by chronic trauma, such as a sharp cusp on a tooth, or toothbrush trauma. It is similar to a callus on your hands or feet. If the source of trauma is removed, then the lesion will resolve. The white is increased keratinization to protect the underlying tissue. The melanotic macule is a benign lesion, usually brought on by sun exposure, usually in the lip or inside the mouth. Smoker's melanosis is increased pigmentation due to elements in the smoke that cause increased melanin production in the mouth. It can disappear if the patient stops smoking and is not considered to be malignant. The exact type of nevi can only be determined by biopsy. As you remember from Dental Hygiene 366, junctional nevi are the ones that are most likely to become malignant. You can see the list of the different types: intramucosal, junctional, compound, and blue. And blue nevus are probably the most uncommon. Students have a tendency to call this a beauty spot, but I would show you by these pictures that it's really hard to say whether or not a nevi is a beauty spot or not. Actinic lentigo is caused by sun exposure and aging. It is a proliferation of melanocytes. The causes are increased sun exposure. They are flat, irregular shaped, and again, they're proliferation of melanocytes. As we leave the category of benign lesions, please be aware that any lesion should be carefully observed. This is why lesion description is critical during head and neck exams. Should a lesion change for any reason, the lesion requires further follow-up. Such follow-up can only be done if the lesion was accurately described in past exams. Premalignant lesions are suspect until proven non-malignant by biopsy. Leukoplakia are white plaques of questionable risk once other specific conditions and other oral potentially malignant disorders, or OPMD, have been ruled out. If the irritant is removed, it should heal within 7 to 10 days. That's the same for hyperkeratosis. If it does not heal, then further examination is required. It is considered a high cancer risk. Erythroplakia is a fiery red patch that cannot be characterized clinically or pathologically as any other definable disease. In other words, there's no other reason why that patch exists. It should be considered high risk and premalignant. Erythroleukoplakia, or speckled erythroplakia, is an abnormal patch of red and white tissue. This too should be considered high risk and premalignant. Dysplasia is a designation determined by histological examination. So in other words, we cannot look at a tissue or a lesion and decide if it's dysplastic or not. It has to be determined by a sample or a biopsy. And it is the presence of cells of an abnormal type within tissue. On the illustration on the right shows the progression in tissue from normal through the stages of dysplasia. When we talk about early detection and complete intraoral and extraoral exams, these early dysplastic lesions are what we would identify and ideally like to detect before the lesion becomes carcinoma. There is a progression from dysplasia to what we call carcinoma in situ. And this is the presence of abnormal cells in the epithelium only. So in situ means in its original place. If undetected or not treated, it may become cancerous. When a lesion is not detected early, sometimes early lesions are not detectable, the cellular changes continue. Severe dysplasia becomes carcinoma in situ. Going onward from the progression from dysplasia to carcinoma in situ, if the process continues, the patient may develop squamous cell carcinoma. This is a malignant transformation of epithelial cells. Its appearance varies. The illustrations on the right show you the various ways that squamous cell carcinoma will manifest itself. The most common sites are the tongue, border, and ventral surface, as you can see on the right-hand side. Alveolar mucosa, the gingiva, and the retromolar area, the floor of the mouth, the soft palate and tonsil, the buccal mucosa, and the lower lip. The causes are tobacco use. That's probably one of the most common sources of squamous cell carcinoma. Heavy alcohol use, increased exposure, sun exposure to lips. This is particularly critical in Hawaii, where we have sunshine all the year round, and people are outside and doing outdoor activities. So this stresses the fact that we need to make sure that when we are outside, that we use some kind of lip balm that has SPF in it. Human papillomavirus is another cause of squamous cell carcinoma, and a depleted immune system. We've talked about melanomas in DH366. Oral melanomas are relatively rare. There is no etiology, and they tend to arise spontaneously. In this slide, we need to contrast the malignant versus benign epithelial neoplasms. So we're looking at gingival melanosis and a melanotic macule. These are benign lesions. A melanotic macule appears much like an oral melanoma, which is figured on the right-hand side. Only by a detailed medical and dental history and a biopsy can the distinction be made. Please note that while the formation of melanomas is associated with blistering sunburns, melanomas like acrolentigenous melanoma may occur on hands and feet which are not routinely sun exposed. And we covered the 4 different forms of melanoma in DH366: the superficial spreading, lentigo maligna, acrolentigenous, and nodular. So how do we as clinicians make a determination about the status of a lesion once it's detective? Again, we need to go back to how we describe lesions. using the ABCDE method: asymmetry, border, color, diameter, and whether or not the lesion is evolving. So this chart is a really nice way of putting these things, comparing the two between a nevus and a melanoma. So if we're talking about symmetrical, nevuses are symmetrical. If you were to bisect the nevus, you would find that they are equal in two parts. Not so with a melanoma. They would not be equal if bisected. The borders are even in nevuses. The borders are uneven in melanomas. Nevuses tend to be one color. Melanomas tend to be multiple colors, sometimes 2 to 3 colors. On the whole, nevus tend to be smaller than a 1/4 inch. However, there are some larger ones. Melanomas tend to be larger. And an ordinary mole will remain pretty much the size and shape that it was in the original examination. Melanomas will tend to change in size, shape, and color. This concludes the lesson on epithelial disorders. As always, if you have issues, questions, or concerns, please do not hesitate to contact me.